Hello, and welcome to the symplr Education Series webinar. Today's webinar is titled Joint Commission Standards for the Hospital Medical Staff with guest speaker Kathy Matzka. Next slide, please. Today's webinar is sponsored by symplr. If you have any questions that come to mind during this presentation, please feel free to submit them via the question box located on the right side of your screen. If we have time at the end of this presentation, we will answer as many as we can for you. You will receive an email with today's slides and the ability to view today's webinar via email within the next 3 business days. Please add kpurdy@symplr.com to your address book to ensure that you get that email. We should have NAM certification following as well. We are waiting to hear back from NAMs. With that being said, I would love to turn it over to our guest speaker, Ms. Kathy.
All right, well, thank you so much. So this session, we're going to cover the Joint Commission standards that are specific to credentialing, recredentialing, privileging, and appointment. Now, I can tell you that I usually do a seminar that lasts a full day on these specific standards. So what we're going to do is we're just going to focus on what the standards are, and we're going to focus on those issues that are kind of hard to come up with ways to meeting them. So we'll try to talk about what it is and how we can meet those standards. So we're going to talk about expedited credentialing, we're going to talk a little bit about temporary privileges, and we're going to talk about telemedicine. So these are all things related to credentialing, recredentialing, privileging, and appointment. So when you look at the standards for the Joint Commission, they have some specific little codes on them so that you can kind of determine how is Joint Commission surveying to this standard. And if there's a DOC icon, that means that there's documentation required. When there's documentation required, that means that they're going to expect to see some kind of documentation somewhere, whether it be a policy and procedure, whether it be something in the credentials file, whether it be something that's included in your bylaws. If it says CMS underneath of it, that means it's something that's required by CMS. So CMS sets these minimum requirements for anybody who wants to provide services to Medicare, Medicaid patients. And they're called the CMS regulations. So the regulations will specify what the regulation is and the interpretive guideline that has to be applied when the surveyors are surveying to that regulation. So the Joint Commission has to submit its standards, to CMS, and then CMS will review those standards and determine if they meet those minimum requirements that are spelled out in the CMS regs. So they will put down in those standards, when you look at the Joint Commission standards, it will reference the specific CMS regulations that are being met by meeting that standard. There's also a section in the standards that says that's called an FSA, and FSA is a focus standards assessment. So what they're saying is this specific standard has an identified risk. So if you are found that you're not in compliance with that specific standard or that element of that standard, then you will have to submit a plan of action for that non-compliance. So we're going to reference which standards do include an FSA as we're going through this. So credentialing, according to the Joint Commission, is that process that we use to verify and obtain and assess the qualifications of a practitioner for that practitioner to be able to provide services at our organization. And it includes how we collect and verify and assess that information regarding their licensure, their education and relevant training, their experience, ability, and their current competence to perform those requested privileges. When the Joint Commission talks about relevant training, what they're meaning here is that you need to verify the training that's specific to the services or privileges that that person wants to provide. So, for example, something that would not be relevant is, say that you have an advanced practice nurse who decides that he's going to go to medical school. So he decides to go to medical school and then goes on to his residency and completes that and then comes to work at your facility. Well, the relevant training is the MD and the residency training. It's not what happened with the advanced practice nurse degree. So you only have to verify what's relevant to the privileges that they're requesting. And the reason that we're doing this is that we want to minimize the possibility that the organization will grant privileges to someone that has fraudulent documents or fraudulent credentials. Privileging is a different process than credentialing, although they do work hand in hand. And privileging, according to the Joint Commission, is a process whereby that specific scope and content of patient care services, which we call clinical privileges, are authorized for a healthcare practitioner by that healthcare organization. And this is based upon the evaluation of those credentials and the performance of that practitioner. So we do the credentialing and we use the information we receive when we're credentialing for privileging to document that they've met their qualifications and that they're competent to do the things that they want to do. When you look at a typical privileging process, it includes developing those privileges, those procedure lists, the forms that we develop, procedure forms or privilege forms. And then we process the application and perform all the primary source verification of all the elements that need to be verified. And then the medical staff makes recommendations to the governing body for privileges that are specific to that applicant. So all the information that is collected is reviewed by the medical staff, and the medical staff makes a recommendation to the governing body. The medical staff does not approve privileges. The medical staff does not approve appointment. The medical staff makes a recommendation to the governing body, and the governing body approves the appointment and privileges. After that happens, you have to notify the applicant of the decision, and you also have to notify relevant personnel, including internal and external entities. So you may have people within the organization that have to be notified when somebody is approved, and you may have external entities that have to be notified too for when someone is approved or not approved or have privileges removed even. And then after those privileges are granted, you have to monitor that practitioner to make sure that they are doing things, only those privileges that they have been granted, approved for, and also that they are doing them well. The Joint Commission standards for the medical staff do apply to licensed independent practitioners. So licensed independent practitioners are those people who are permitted by law, that means your state regs, federal regs, and by the organization to provide that care, treatment, or services without having direction or supervision. So advanced practice nurses who are providing a medical level of care, that means that they are making independent diagnosis and treatment decisions. Those people are credentialed and privileged through the medical staff function. Now, you may find that you have employed practitioners and some things are done by HR, but the full credentialing and privileging has to go through your medical staff process, just like a physician would if those practitioners are providing a medical level of care. Also, the people who are providing those services have to be functioning only within the scope of their licensure and within the scope of the privileges that they've been approved for. Medical staff appointment is required by the medical staff to develop the criteria. So the medical staff will develop and apply that criteria for membership. Typically, this is spelled out in medical staff bylaws. This is where we'll see the criteria for membership. And so it's approved by the medical staff, and then then it's applied consistently by the medical staff. And the criteria that is designed is supposed to be designed in such a way that it assures both the medical staff and the governing body that patients are going to get quality care, treatment, and services by those practitioners who are granted these privileges. Of course, Joint Commission requires that appointment doesn't go over 2 years. You can have a lesser time of appointment, but you can't exceed 2 years for an appointment cycle. You can't take into consideration when granting privileges gender, race, or creed, national origin. None of that can be part of your criteria for a medical staff appointment or considered or at medical staff appointment. And again, the medical staff recommends appointment and the governing body approves that appointment. There's also a requirement that before someone is granted privileges, that the organization has a process to determine whether or not they have sufficient space, equipment, staffing, and financial resources to be able to provide that service. So what that means is that if someone comes to you and says, gee, I just took a course on robotic surgery, and I would like to apply for privileges for robotic surgery at your facility. Well, if you do not have that equipment, you can't grant privileges for robotic surgery. And if the hospital determines, well, gee, maybe that's a service that we would like to provide. Well, if that's so, then there needs to be some kind of a process to determine, do we have sufficient space? What do we need to do to purchase the equipment? Do we have the money to be able to do this? What kind of training are we going to have for our current staff in order to be able to provide that service within our facility? So a hospital has to consistently determine that it has the resources needed for the requested privileges. So again, these are those areas that have these FSA tags next to them, which just means something that if you do not meet those requirements, then you're going to have to follow up with a follow-up report afterwards. Credentialing is also required to have a defined process. So that means, again, that something's got to be written out. So that typically we see credentialing basics, the basic outline spelled out in bylaws, but we might have a policy and procedure that addresses things in a little more detail. And that's okay, as long as the basic steps are contained in your bylaws. You can have the rest of the more detailed in a policy and procedure. The credentialing process needs to be based upon the medical staff making the recommendations and the governing body approving. So what we're seeing here is that the appointments and privileges have to be recommended by the medical staff and approved by the board, but the process itself also has to be recommended by the medical staff and approved by the board. And part of the requirements for Joint Commission is that there is verification of identity. And the verification of identity means that somebody has to actually view that ID. Just like copying a copy of a driver's license and sending it in with the application does not meet the intent of the standard. The standard does require that somebody actually view that ID prior to that person providing services. And this can be done in a number of different ways. You can have someone come to the medical staff office and show their ID. It can be done at the time that they get their badge made. If it's an HR person, that somebody's being hired, it can be done as part of the HR process. If it's somebody, a locum tenens, say, showing up for the midnight shift on Friday night in the emergency department, somebody needs to verify that person's identity, whether it be somebody from security or a nursing, a night supervisor, or whatever. But there has to be a process for doing that. The credentialing process also has to include that requirement that that we're verifying relevant training, current competence, current licensure, and they want this to be in writing and come from the primary source if possible, or you can use a credentials verification organization. Now, the Joint Commission does also allow designated equivalent sources, for example, the AMA physician profile for verification of ACGME accredited training, or you can have a secondary source like the AMA profile is there to a display agent for the ABMS board certification. So you can even use that for board certification. You also have to verify licensure at the time of initial granting of privileges, when those privileges are renewed, anytime there's a revision in the privilege, and then when license expires. So you might find that you have 3 or 4 verifications within a year's time, because you might have, for example, somebody's license might expire and you have to renew it. And then they have a recredentialing, so you have to do it at recredentialing. And then they may request an additional privilege, a new privilege, and so you might have to re-verify it again. So you will find sometimes that there's a number of licensure verifications over a short period of time that you'll have to maintain. And each time you have to re-verify that license. The privileging has to be objective and evidence-based. So this means that people who are granted privileges have to follow criteria, have criteria to be able to do that. So because it needs to be objective and evidence-based, and you can't do that if you don't have some type of criteria that is established for granting those privileges. There's a requirement that if anybody who is providing care has a current licensure, certification, or registration, their hospital has to have a clearly documented procedure for processing those requests for privileges, and that process is approved by the medical staff. Now, if you notice, some of the standards for the Joint Commission say the hospital has to do something. Some of them say the medical staff has to do something. So there's a delineation within the standards of who has responsibility for some of these functions. So, they do require that the hospital has this procedure for processing requests for applications for privileges, and that process has to be approved by the medical staff. So, giving an example, you may have a medical staff policy for privileges, or a medical staff rule and regulation or bylaw for a request for privileges, that somebody has to request privileges and how that request has to happen. But then you might have a hospital policy that says when a request for privileges is received, here are the steps that we follow. And if you have that type of the Joint Commission gives the hospital the requirement for having this documented procedure for processing those requests, but it has to be approved by the medical staff. Privileging also has, requirement that the medical staff does make the recommendation and the governing body approves. Again, you see some of the stuff that's repetitive, and that's because it is mentioned more than one time when you read through the accreditation standards. The criteria for privileging has to include that there's that you've done primary source verification of that licensure and relevant training, that you've have some kind of evidence that that person is physically able to perform those requested privileges. And we do that by getting an attestation, or we may require a physical examination, depending on the circumstances. Or the hospital is required when privileging to get data from professional practice review from another organization where that applicant currently has privileges, if that data is available. So that is a requirement that you're supposed to at least try to seek that information out. When you're renewing someone's privileges, then the medical staff criteria has to include that we're looking at that person's performance within the hospital. So this would be where we would look at the ongoing evaluation, professional practice evaluation that had been done, and the quality metrics that we've been collecting, and that's reviewed at the time that the privileges are renewed or reappointed. There's also a requirement for recommendations from peers and or faculty that happen at the time that we're granting privileges. And the hospital has to consistently evaluate each of these for everyone that has the same type of privileges. Also, things that have to be looked at when privileging is whether or not there's any kind of challenges to someone's licensure or registration. When we say challenges, we mean that there are any kind of disciplinary action or any kind of reviews or investigations that were done. We look at voluntary and involuntary relinquishment of a license or registration. So somebody had to give that up voluntarily or involuntarily. We have to take a look at it. Terminations of medical staff appointment or limitation, reduction, or loss of clinical privileges, whether voluntary or involuntary, have to be looked at. So these are why we have those questions on the form that says, have you had any disciplinary action against your license? Have you had voluntary or involuntary relinquishment of or termination of medical staff membership or loss of clinical privileges? So that's why we ask those voluntary and involuntary on those applications. It is something that, remember when I first started doing credentialing over 30 years ago, at that time, that was something that Joint Commission was really focusing on, is that your application had both voluntary and involuntary on it. And I can remember having to change an application way back then because we only asked for involuntary terminations or actions that were taken, and we had to add that word voluntary to the application. Then before you grant privileges, the medical staff has to also look at whether or not there's any kind of an unusual pattern or an excessive number of professional liability actions that resulted in a final judgment. So when we talk about professional liability actions and a final judgment means that a judge or a jury determined, looked at this, that it went to trial, and a judge or a jury looked at it and said, yes, there was a final judgment here. You were wrong, and you have to pay. So this is what they required you to look at, an unusual pattern or an excessive number. And this can be something that is very difficult to do. Your medical staff has to look at these cases and determine whether or not there's whether or not this is reflective of an excessive number or an unusual pattern. So if you have, for example, somebody that had one medical malpractice lawsuit last year and one the year before, and both of them resulted in a final judgment, and they have to look at it and say, well, are those 2 in 2 years an excessive number? So that's up to the medical staff to look at that and evaluate it. We also have to have documentation of health status, and this is something that we will typically, like I said earlier, get in an attestation that, where they attest that their health is such that they can perform the privileges that they're requesting. And again, this is another place where they say that you have to have relevant practitioner-specific data compared to aggregate data when available, and also morbidity and mortality data when available. So before granting those privileges, or before the medical staff recommends it to the board, the medical staff has to evaluate this specific data about how that person is doing compared to aggregate data when you have that available. Then the attestation about health problems, health issues, they only have to be specific to how they would affect someone's practice, and that evaluation needs to be documented in the credentials file. Typically, we have it, like I said, in a statement on a credentialing application. But for initial applicants, that health status has to be confirmed, and it can be done by a number of ways. The director, if somebody coming through you right out of a training program, the director of that training program can be the one that provides that documentation of health status. The chief of staff or services at another hospital where someone is currently working can provide that information. You can have somebody that is a doctor that is approved by your medical staff that does it. You can send them to maybe an employee health doctor or so forth. So there's a number of ways of doing that, but that initial applicant health status has to be confirmed. Now, there also has to be a process whereby if there's any kind of a doubt as to whether or not this person can safely perform these privileges, then there needs to be an evaluation by some type of another person, maybe an external source, a doctor that you send them to, or an internal source, maybe like an employee health physician or somebody that is on your medical staff that has agreed to do those evaluations. So if there's any kind of doubt about whether or not that person can safely perform those privileges due to a health issue, then that needs to be looked at by someone else on the outside or on the inside. There has to be a data bank for all initial grants of privileges when privileges are renewed and whenever new privileges are requested. So even though the Joint Commission requires it on initial, renewal, and when new privileges are requested, keep in mind that the Healthcare Quality Improvement Act does require that you do it every 2 years. So you have to make sure that you are querying the data bank at least every 2 years on everybody who's been granted privileges. The hospital has to have a process to determine if it has adequate clinical information in order to make its decision. So this is another area where the Joint Commission puts it on the hospital. So the hospital has to have a process to say, do we have enough clinical information to determine whether or not we can grant, limit, or we should deny these privileges. So again, this is a process that the hospital has to have. And peer recommendations are also required. Peer recommendations are someone who's in the same professional discipline as that person and actually has some knowledge of that person. And so it needs to be someone that's currently working with them or has most recently worked with them. I've seen many peer references when I go and evaluate a hospital's credentialing, and I'll see, how long have you known the applicant? And they'll say, 15 years. Well, how do you know the applicant? We went to training together. This person might be in a different state. Well, somebody who you trained with 15 years ago is not somebody who has current knowledge of your ability if that person hasn't worked with you during that time. So it needs to be someone that knows what's going on, a knowledge of their ability. And you have to get these for all new applicants for privileges. If you are recredentialing someone, you do not have to get these specific peer recommendations, only unless you can use them when you don't have enough practitioner-specific data. So you don't have to routinely send out these peer reference forms like we do for initial appointment on recredentialing, unless, of course, your policies and procedures say that you're going to do it. But the Joint Commission does not specifically require that you send out those peer references at the time of recredentialing. So, but there are also some requirements that have to be a part of a peer recommendation, and so some of these are part of the ACGME the core competencies, and some are not. So the medical and clinical knowledge has to be evaluated, their technical and clinical skills, their clinical judgment, their communication skills, professionalism, and interpersonal skills. All of these are areas that have to be evaluated by peers when those peer recommendations are made. So if your peer recommendation form doesn't include each of these areas, then you probably need to revise it and add this to it. Now, you may have something that doesn't say, for example, it might not say professionalism, but it may say something like, that they conduct themselves in a professional manner or something like that. So as long as you're meeting the intent of that, that's okay. Or it may not specifically say interpersonal skills. It may say something like ability to relate to others and interact or something like that. So as long as you're covering that, it's okay. But you need to look at your peer recommendation form and see if it includes all of these areas in it. There needs to be some time period specified in your bylaws for getting a completed application through the process. So a completed application is one that's everything's back on. It's got all the recommendations are back, all of your verifications are there, the application is complete, everything is ready to go, and it's just ready for that first level of review, whether it be the department chair or credentials committee or an MEC. So once that application is complete, there needs to be a time frame specified in your bylaws for approval. The Joint Commission doesn't say it has to be within a certain amount of time. They don't say you have to do 180 days or 30 days or 60 days or whatever. They just say that your bylaws have to include a requirement. So whatever your bylaws include is what you're going to be held to. There's also a requirement that Surgical Services Department has a current roster that lists practitioner surgical privileges. Now, this can be done by course, having a paper copy of it in the OR, which is kind of a headache to maintain. It's better to, if you have like a credentialing software, let your surgical services people have the information about, access to the information about practitioner surgical privileges, or you can, if you don't have credentialing software at your facility, then what you can do is you can scan a copy of the privilege form and put it out there on an intranet that only people on the inside can access, and let them be able to access it that way. But they need to be able to know who has privileges, so that when, you know, somebody wants to schedule something, it's, you know, that there's a way for them to look it up and see if that person has privileges to be able to schedule that procedure. And then whenever there's a change made in someone's clinical privileges, that privilege form has to be updated. There is a requirement also from the Joint Commission that's kind of a no-brainer, that you actually have to have a process for looking at, analyzing, and using that information you've received. That process has to be clearly defined, and the hospital develops these privileging criteria based upon the medical staff recommendation, and the governing body, again, is a final approval, final authority. Criteria has to be consistently applied. And again, you can't use gender, race, creed, national origin. And they do require that your hospital does complete the process in a timely manner, so that the time frame that you have defined in your bylaws needs to be something that's reasonable, so that it is a timely, you can't say, something like, well, a completed application has to be processed within 2 years. That wouldn't be timely. You make it something that's reasonable. So also looking at that section on analysis and use of information received, the privileges, they can't go over 2 years. So appointments can't go over 2 years, privileges can't go over 2 years. And the criteria that the facility uses to make those appointment and privileging decisions needs to be directly related to the quality of healthcare treatment. And if you have a case where someone is denied for what we call economic reasons. So for example, you have someone who requests privileges to read EKGs, but you deny those privileges, or you tell them that everything else that they requested is approved, but we're denying your privileges for EKGs because we have an exclusive contract for EKGs, and only certain people who are party to that contract can have those privileges. So that would be something that would be an economic criteria. So if you're going to have specific criteria like that, in one element they say that the criteria has to be directly related to quality healthcare treatment or services. And then the one right under it says, but if it doesn't, then you have to there has to be some kind of evidence existing that you've looked at the impact of that resulting decision on how that care is going to be provided. So they don't say that you can't use it. It's just that if you're going to use it, that you have to evaluate whether or not this is going to have a negative impact on patient care. Usually when we go with an exclusive contract or, some kind of other economic criteria, we're doing it because we've established that this exclusive contract is going to help with standardization and will help to, improve patient care. There has to be a notification of the practitioner of the decision to grant, deny, revise privileges. And if you deny them, you have to tell them why. Also, that decision needs to be distributed and made available to internal people and external people that need to know. So, for example, if somebody, is approved for new privileges, we notify the operating room, we notify nursing services, and so forth. If there's somebody that's denied privileges and it's something that's reportable to the National Practitioner Data Bank or your state licensing board, then that also has to be done. Whatever process you have for that distribution, the medical staff has to approve it. So you have typically a hospital process that says these are the people that are going to be notified when when somebody's granted privileges or has a privilege change. Then the medical staff needs to approve that process. And also when somebody is denied, if there's any availability of due process, hearing appeal, so forth, then the hospital has to make that practitioner aware of that being available to them. The CME is also a requirement by the Joint Commission. They require that the organized medical staff prioritizes hospital-sponsored education activities. And these activities that are sponsored by the hospital should be related to the type of care that is being provided by the hospital, of course. And also include if there's any kind of findings from performance improvement activities. So say, for example, you have a problem with post-op infection rate being high, then maybe your organized medical staff might say, gee, let's get somebody in here to talk about, post-op wound infections, post-op surgical infections, and let's, try to get this infection rate down. There is a requirement that everybody that's a licensed independent practitioner has some kind of documented continuing education, and then that documented CE, continuing medical education, is included and reviewed at the time of their renewal or revision of privileges. Okay, we're going to switch gears just a little bit here and talk about expedited credentialing. An expedited process is not a requirement, but it is an option that an organization can have. The expedited process is an actual board process. So what happens here is that the board can delegate to a committee that has at least 2 members the ability to make the privileging and the appointment decision for the entire board. So rather than waiting for the full board to meet, the committee of 2 people would be, or at least 2 people would make that decision on behalf of the board. So in order for this to happen, the medical staff has to develop and utilize criteria for that expedited process. So this has to be something that's spelled out by your medical staff. If that applicant has an incomplete application, or if the medical executive committee makes a final recommendation that's adverse or has some kind of limitations, that person would not be eligible for the expedited process. So these people that are going to the expedited board processes are people who are the slam dunk type people. So these are the people that have a complete application, there's no problems identified with it, and it's something that the medical executive committee makes a positive recommendation to the board. So these are the ones that would be able to go through. So the Joint Commission has some what they call situations that need to be evaluated on a case-by-case basis and would usually lead to ineligibility. When this standard first came out some years ago, it said that it would lead to ineligibility, but now they've qualified it with the word usually. So if there's a current or previously successful challenge to licensure or registration, an involuntary termination of medical staff membership, or involuntary limitation, reduction, denial, loss of clinical privileges, or that unusual pattern or excessive number of professional liability actions that resulted in a final judgment. These were situations that would usually lead to ineligibility for the expedited process. But let me give you an example. Say that you're a radiologist that's working at a hospital, and the hospital decides that they're no longer going to offer in-house radiology services, and we're going to have everything go through a telemedicine entity that's going to read all of our x-rays and all of our tests for us. So therefore, my contract as a radiologist with that organization has not been renewed. My privileges and a medical staff appointment are tied to that contract. So that to me is an involuntary termination of my appointment and privileges. So that would be a case where, gee, should I be ineligible for an expedited review just because a hospital, did not decide to continue contracting with our radiology group. So that would be an area where, you know, it'd be something that your medical staff might say, oh, that's not a big deal. You know, there's no quality of care issues here. It was just a contractual and economic decision by that hospital. So we don't want to exclude that person from the expedited process just for that reason. So these have to be looked at on a case-by-case basis. Okay, the next thing I want to talk about is temporary privileges. Again, this is something that is allowed to happen. It's not a requirement that a hospital grants temporary privileges, but it is an option that that a hospital has. So temporary privileges are can happen in two ways in the world of Joint Commission. You can grant temporary privileges when you have an important patient care, treatment, or service that has to be provided to a patient. And they do not say how long these important patient care need temporary privileges can last. They just say that your bylaws have to specify how long will this happen. So your bylaws might say, if there's an important patient care need, we're going to allow temporary privileges for 30 days or 60 days. So your bylaws, medical staff bylaws, define that for an important patient care need. What is an important patient care need? Say that I have 2 obstetricians on staff and one of them had to have an emergency appendectomy, and we're bringing in somebody to fill in for that person. That would be an important patient care need. So we need 2 obstetricians because somebody has to cover. You know, so we have an emergency department and we're having problems with staffing our emergency department, and we're kind of short anyway, and then somebody ends up you know, having a family emergency and has to take off for a while. Well, then we have to bring in a locum tenens to fill that slot. That's an important patient care need, because if we don't have that, then those patients aren't going to be able to be taken care of. So, and the other thing is, if we have an applicant that has a complete application, there's no red flags in that application, no concerns, and all we're doing is waiting for the medical executive committee to make its review and the governing body to approve it. So if we have someone who meets that qualification, we've got an applicant, it's ready to go, you know, the MEC is going to approve it because everything's good in it, we're just waiting for the MEC and the governing body to approve it. That's another case where you can grant temporary privileges. Temporary privileges are limited to 120 days for new applicants, though. So if you have someone who has a complete application and all it's waiting for is the medical executive committee to meet and make a recommendation, and the governing body to meet and make an approval, you should be able to get that done within 20 days, 120 days. That's a pretty liberal amount of time there. So if you can't get that done within 120 days, you probably got some kind of a system problem at your facility. Again, the specific limitation for patient care need is not addressed, just needs to be time limited and spelled out in your bylaws. Temporary privileges are recommended by the medical staff president or that president's designee, and they're granted by the hospital's CEO or designee. So again, we got a medical staff recommendation and we got the CEO who is functioning, you know, on behalf of the governing body, granting those privileges. So again, it's a medical staff recommendation and the CEO or designee is granting those privileges. For an important patient care need, the Joint Commission requires that you verify that they do have current licensure and that you have current competence. There's no requirement that you verify every hospital affiliation that anybody has ever had. The Joint Commission doesn't have that type of a recommendation or requirement anyway, but for an important patient care need, you have to make sure that their license is valid. You have to make sure that they are currently competent. And we can get that current competence by writing to a current place where they've worked or the place they've most recently worked, and getting somebody that is a chief of staff or a medical director or somebody that is a clinical department director, writing verification that they are currently competent for the things that they want to do. Peer recommendations can verify to current competence as well. For new applicants, things are a little bit stricter. For new applicants that are, have a complete application, the minimum that has to be there in order for that application to be continued complete is that they have a current license, you've verified their relevant training experience, you've got verification that they're currently competent, and their ability, that health status, their ability to perform those privileges that are requested. Any other criteria that's required by your medical staff bylaws. If your medical staff bylaws require that you verify every affiliation that anyone has ever had, then that needs to be there. So any other additional criteria that's required by your medical staff bylaws have to be there in order for that to be a complete application. You also have to have the data bank, of course, report back. So in order for that to go through that process, that application has to be complete. They can't have any kind of successful challenges to licensure or registration, no involuntary termination of appointment, or reduction, denial, or loss of clinical privileges. So this is one of those applications that is a complete and clean application and so then in that case, if you have a new applicant, that you can grant those temporary privileges. Another area where Joint Commission has some requirements, but it's not something that you have to do, is grant privileges for telemedicine. I don't know how many of you, I'm dating myself with this cartoon, but we're not too far from from this now, where we have people doing diagnosis and treatment via video. When this first came out, it was pretty far-fetched, but we're pretty much there now. So telemedicine, the Joint Commission gives you several options. You can fully credential and privilege them per the medical staff standards, the way you do everybody else on your staff. Or you can privilege them using the credentialing information from a Joint Commission accredited distant site. So that means that it's another facility that is Joint Commission accredited. You can use their credentialing information. They can copy stuff out of the credentials file and send it to you, and you can use that information. Or you can use the credentialing decision from that distant site if it's Joint Commission accredited. And this goes for either a hospital or an ambulatory care organization. So in that case, what you're going to end up with is just a listing of those practitioners that says, here's the people that we would like to have you take through your privileging process, and it may be just a list of those people along with the list of the privileges that they're requesting to have approval. So you get 3 different options with Joint Commission. If you're going to use that decision from the distant site, they have to be Joint Commission accredited, and you have to verify that they are following those standards, and you can do that by getting a copy of their policies and procedures and evaluating those. That practitioner has to be privileged at that distant site for the things that they want to do at your place, and the distant site has to give you a current privilege list, and that's if you're if you're Medicare approved hospital, then you have to get that. Now you might have to get the actual privilege form, or you may just get, like I said, a listing that has the person's name and what those privileges are. Also, the originating site, which is the place where the patient is, has to do an internal review of that practitioner's performance and send information back to that distant site. At a minimum, you have to send them complaints and adverse outcomes that are related to sentinel events that may result from that telemedicine. So, for example, you might have teleradiology, and you might have to feed back to them things like, X-rays that weren't read appropriately, or people that didn't, maybe they're having problems with timely reading of X-rays or so forth. So you have to feed back information to them. Also, there is a requirement that distant site practitioner is licensed in the originating site state, so they have to be licensed in the state where they're providing care to that patient. Using that credentialing and privileging decision from the distant site is also, there's some standards in the leadership section, and they do provide that the distant site governing body is responsible for making sure that they are have a process that is consistent with those credentialing and privileging requirements. They put that on the distance site. The medical staff at the originating site relies on that information and makes a recommendation to the governing body, and the governing body then grants those privileges based upon that originating site recommendation. So you have to have a, the medical staff still has to make a recommendation for privileges, and the governing body still has to approve those privileges. There's also some requirements for what has to be in the telemedicine agreement, including that the distance site is a contractor of services and is furnishing those in a manner that allows you to be in compliance with the conditions of participation. And also the originating site has to have the written agreement that says that those credentialing and privileging processes of that distance site do meet the Medicare conditions of participation for telemedicine. Also, the medical staff has to define what kind of, if there's any kind of process for supervision of someone with appropriate privileges, any kind of requirements of supervision have to be spelled out in that agreement. I want to just mention that the Joint Commission did have a recommendation for some changes in these telemedicine regulations, and they had a review of the proposed changes that was sent out, and it ended in March. So there are going to be, some of these were deleted, some of them were consolidated, some of them were moved just to LD, from medical staff to LD. So these standards are probably going to be changed in the near future. So, keep that in mind and be looking for those changes. Also, something else that was recently changed for independent pathologists, this is in the LD standards, not in the medical staff standards, but effective January of this year, we're not required to credential and privilege pathologists who provide those diagnostic services through a reference or contract laboratory. As long as that lab is CLIA compliant, we no longer have to credential those people that do not come to our hospital. So, but if that service or consultation is done in the same laboratory or in our organization where they're collecting, where that specimen was collected and prepared, then we do have to credential and privilege them. But the ones that we're just sending out to someone else, we no longer have to credential those people, which is going to be a time savings for us. The idea is that the clinical laboratory improvement amendments have some pretty strict requirements, and if you're following those, then you're going to be appropriately credentialing these people anyway. So just some closing comments. The Joint Commission credentialing and privileging standards do apply to all licensed independent practitioners who are granted clinical privileges. They do not apply to people who are not functioning independently, dental assistants, private nurses, and people like that. They do not apply to them. They do require documented processes, and you need to pay attention to all those ones that have the DOC. Medical staff involvement in all phases of credentialing is essential. They need to be involved every bit along the way, because good processes that are consistently applied will result in improved patient safety and provision of high quality patient care. Okay, now a quick word from symplr.
Thank you so much, ma'am. This is to just talk about how symplr relates to this topic. Symplr has the Cactus Provider Management Platform, which is the full life cycle integrated for your providers. Next slide, please. We offer provider credentialing, which is seen as the gold standard in provider credentialing across this organization. We are a web-based solution. We have powerful automation of credentialing workflows. We have a single source of truth for the provider information. We can scale either up to your very large complex organizations, or we can be in smaller facilities. We have primary source verification. We also have powerful and very flexible reporting. Next slide, please. Provider privileging. We have a comprehensive privileging content library that, as you can see, has a lot of specialties and delineated privileges. We can also privilege link to CPT and ICD 9 and 10 codes to help with your professional practice reporting or OPPE, FPPE reports. You can do a real-time privilege lookup, and you can also do multi-facility reporting. If that is something that is interest to you, please reach out to us at sales@symplr.com. Now it's time for the Q&A portion of our webinar. If you do have any questions that have come through, please feel free to submit them in the questions box on the panel on the right side of your screen. If we do not get them to them today, we will, Kathy and/or symplr can reach out to you to best answer your questions after this webinar. We did have quite a few come in today, Ms. Kathy. One quick thing I would like to clean up or clarify is we will be sending out a copy of this PowerPoint along with a link to view the recording of this webinar. It will be coming from an address kpurdy, P-U-R-D-Y, @symplr.com. She will be sending those out to y'all within the next 3 business days. So if you will add it to your address book, that is how you will get that information along with your NAM certificate once we are approved. Like I mentioned earlier, it is still in the review process, but we do not foresee them denying us. So that will be in the emails as well. First question, Ms. Kathy, is what is the best practice for verifying IDs for telepractitioners?
Well, that's a difficult issue. I know that there was something that the Joint Commission put out a couple years ago about that because of that question, and the best practice that they mentioned was including in your contract with that telemedicine entity that they will verify the identity on their end.
Okay, fantastic. Next one. Do surgical assistants need to go through the credential and privilege process with the medical staff office, or could they go through a modified HR process or something else?
Okay, if they are providing, if they are meeting the definition of surgical task as spelled out in the CMS regs, and if for surgical assistants, if they're cutting tissue, if they are suturing, then they would be meeting that definition. And if that's the case, then they do have to be granted privileges to do those surgical tasks. They can be handled through HR. If they're an employee, especially, that makes perfect sense. They can be handled through HR, but the privileges for those surgical tasks have to be approved by the board, and it has to go through the medical staff evaluation process. And when they're granted privileges, of course, then there's focus on ongoing professional practice evaluation.
Okay, thank you, ma'am. Next up, for off-site, example, teleradiology, providers who are physically located out of state, verifying the IDs, that would be the same as the question before, yes? It would be within that entity? All
right,
right,
you just ask the contracted entity to do that for you.
All right, fantastic. Next up, can you clarify the credentialing and privileging of independent pathologists? Our specimens are collected at our facility and then sent to the lab. To the pathology group used is not owned by our facility. Do we need to credential these pathologists?
You do not. As long as they're not coming to your facility and performing those evaluations of tissue in your facility, you do not have to credential them. If you're sending them to the reference lab and it's a CLIA approved lab, you do not have to credential them or grant privileges.
All right, next up, NPDB reports for privilege changes. If our organization uses the continuous query option with the data bank, do we need to actually print out this report?
You do not. If you have a continuous query option, you do not have to print out every time you're recredentialing or adding new privileges. You don't have to print out the thing showing that they're enrolled in continuous query. Joint Commission may ask you at the time of your survey to show you documentation that they're enrolled in it, but you don't have to print out that piece of paper and put it in the credentials file. It's not necessary. As long as they're in, you're fine.
All right, thank you. The next one's kind of long, so I would like to apologize. For the two-year reappointment cycle, is it the effective dates based on the board signature or our determined reappointment cycle? For example, if the board approves a reappointment, on April 24th, 2018, but we state in their board letter that their privileges start on May 1st, 2018 and end April 30th of 2020. Is that acceptable, or do we need to have their privileges start on the date the board signed off?
That's a good question, and that is something that is addressed on the Joint Commission's website in a frequently asked question, and they specifically say that you make it the effective date. So if you approve them on March 13th for April 1st, then April 1st is their approval date. So you should be making those, taking those to the board in advance of them expiring, and making it effective the date that the, one expires, March, 31st, and next one starts April 1st.
All right, fantastic. Thank you, ma'am. Let's try and squeeze in one more. For telemedicine, do you have to verify licensure monthly and do your own MPDB if you use the distant site decision?
You don't have to verify it monthly. You just verify it at the time that you do the initial credentialing and the recredentialing, just like you would for any other provider. You do have to do a data bank on it, on that person. That's one of the things that when they, they wrote those changes in the CMS regulations to allow for using the information or the credentialing and privileging decision of a distant site, but the Healthcare Quality Improvement Act is still there. So the Healthcare Quality Improvement Act still has to be followed. So if you are granting privileges, prior to granting privileges, you have to do a data bank. Also, some state regulations may specifically say that a hospital has to, prior to granting privileges, query the licensure department to determine that that person has a license. If you have that type of a state regulation, you also have to follow your state regulations. So you just do it, verify the, I don't know where the monthly thing came up with, but there's never been a requirement for a monthly verification of license.
Okay, thank you, ma'am. We still have quite a few people on the line, so I'm going to continue going with some questions. We've actually had quite a few roll in. Next one,
sure.
Regarding telemedicine privileging, can a hospital use PSVs from any previous Joint Commission employer?
If that is the hospital that they're contracting with, they can. So you can use the credentialing and privileging information from the entity that you're contracting with, the Joint Commission accredited entity that you're contracting with. But if it's not a hospital that's a party to that contract, then no.
Okay, thank you. Next one. Have you had any experience with telemedicine credentialing between a Joint Commission distant site and a DNV originating site in regards to delegated credentialing?
No, I have not. I do know that DNV follows CMS regs. So if you're a DNV accredited hospital, you can use the credentialing and privileging decision of a Joint Commission accredited hospital. But if you are a Joint Commission accredited hospital, you cannot use the information or the decision of a DNV accredited hospital. Joint Commission specifically requires that you have to use a Joint Commission accredited hospital or entity.
Thank you. Next question is, what is the best practice for viewing practitioner government issued IDs that you have seen in the past?
Well, viewing the government issued IDs is something that I don't like seeing one way of doing it. I like seeing multiple ways of doing it. And it just depends on what the circumstance is. So for example, if you're making if everybody has to do an interview and onboarding before they are able to provide services to a patient, it could be done by the medical staff office. If it's an employee, it can be done by HR during the HR process. If it is somebody who is, if you issue name badges to practitioners and medical staff and they cannot provide services till they get a name badge, it can be done at the time they get their name badge done. And like I mentioned earlier, if it's somebody like a locum tenant that's showing up in the middle of the night to fill a shift in the emergency department, it can be safety and security or nurse manager or somebody like that. So you need, you know, having multiple ways of doing it is probably the best option depending on what the circumstance is.
Fabulous. Thank you, ma'am. Next question. Do perfusionists need to be credentialed or privileged?
Some hospitals do credential perfusionists, and it just depends on what the service is that's being provided. Perfusionists, if they're, some hospitals do and some hospitals don't. Some hospitals just handle it through a credentialing, through a contract. If they are making independent, again, it gets back to if they're making independent patient care decisions, then they have to be credentialed. If the perfusionist is, you know, running the pump and the doctor is directing everything, then they're not functioning independently. There's always a surgeon in there working with them. So it just depends on how the hospital wants to handle it. But if they're not performing independent medical diagnosis and treatment decisions, then they do not have to be credentialed.
Excellent, thank you. Another one that's rolled in. If one of our hospital providers wants to do telemedicine for a patient at one of our clinics, does he need special telemedicine privileges?
No, this is one of those things that I see quite often too, is telemedicine is not a new privilege. Telemedicine is just a different way of doing what we do. So if you have a psychiatrist who is doing video evaluations of a patient in the emergency department, you're giving them privileges to do those evaluations. You're not giving them privileges to do them via video. If you're reading an X-ray, you don't have to have privileges to do it via telemedicine. You're reading the X-ray. Before we ever had the word telemedicine, people were, transmitting still images for interpretation. So it's not, telemedicine is not a privilege. Telemedicine is just one way of doing a procedure.
Excellent. Thank you, ma'am. I don't want to keep everyone too long. We do still have a few questions to get through. I will be sending those to Kathy offline, and you can reach out. You can reach out that way, or you can reach out to symplr directly at communications@symplr.com to have those questions answered. Again, you will be receiving an email with the download of today's slide deck along with your NAM certificate when and if we get approved, and the ability to view today's recording. Kathy, is there anything you'd like to say to our audience in closing?
Oh, just thank you all for hanging in there, and I'm happy to answer any questions. Even if you didn't share your question online, shoot me an email, kathymatzka@kathymatzka.com, or give me a call. You've got my information. I'm happy to chat with you.
Excellent. Thank you so much, ma'am. Again, on behalf of symplr, we'd like to thank Kathy so much for joining us for this webinar, and we would like to thank everyone for joining us as well. Please be on the lookout on our website for upcoming dates with Ms. Kathy herself and all of our other webinars as well. Once again, thank y'all for coming out and hanging out with us today, and we wish you a great rest of the day. Have a good one, everybody.